Welcome, everybody. I really appreciate everybody coming, and wanted to start out by really expressing my thanks to Dr. Steve Rosenblum and Rosalind Zerver for their support of the Adult Congenital program over the year, and that has supported our visiting professorship as well here today. So I'd like to really welcome Craig Broberg, who is my friend and colleague in adult congenital heart disease, who comes to us from Oregon, and he is the director of the Adult Congenital program there. Craig did his undergraduate work at Brigham Young and then went to UCSF for medical school, followed by Washington for residency, and then fellowship in Oregon, and then went to London at the Royal Brompton for his adult congenital training, working with really a wonderful group there, Michael Goudzoulis and company, for adult congenital, and then returned to Oregon and has moved up through the ranks there and is currently the Manisha Endowed Chair of Cardiology and Radiology at Oregon Health Sciences University. Rather than reading through his CV, which would probably make him very uncomfortable, I just want to feature, I think, two things over the course of his career that I really think about with Craig. And the first is related to the development of multi-center research in adult congenital heart disease. And as a field, we have really struggled to get our footing with this. There have been a number of organizations, one called ARC, which started very early in the process, and Craig was essentially a charter member of that. But we really struggled to work together and struggled to get funding. And all in the background, Craig was always in there applying for AHA grants and working. And he has really, I think the culmination is the project we'll probably talk about a little, is looking at essentially a worldwide study for patients with systemic right ventricles. And he was really able to pull together centers from all around the country, all around the world, and doing so in, I think, a really very humble way and a way of collaboration. And, you know, everybody knows Craig in the field, and it's really because he works, it's such a wonderful collaborator. The other thing to mention, we were just talking about this before I came up, is that he has run a meeting for adult congenital heart disease in outside of Portland, beautiful, in the Skamania Lodge in the Columbia River Gorge. And David San, who is a wonderful pediatric cardiologist, started this symposium many, many years ago. And Craig, being the program director at Oregon, inherited that job. And Craig has really put his heart and soul into this meeting. Everybody in the field looks forward to this. It is a beautiful place for a meeting. And Craig not only runs a wonderful scientific meeting where we work together, he ends up organizing hikes. He is running the shuttle, you know, all of these things. It's a wonderful effort. We all appreciate. If anyone ever wants to get a wonderful exposure to adult congenital heart disease in a wonderful environment in the Columbia River Gorge, it's in June it's a few years in the future. We just were there in June, but it has been a wonderful contribution, I think, to our field that Craig has done such a wonderful job with that. So I will go ahead and have him come up for a talk. He's going to talk about, I'm not sure where he's going to go with Wolverines. I don't think that Wolverines have a systemic right ventricle, but I am glad to hear about it. So welcome, and we're very happy that you're here.
And that's very kind. I am honored to be here with you today. I think of Michigan as a significant place of historic and academic significance, and I think about the people that have probably stood at this podium over the years, and it truly is an honor to be joined to join you guys today. Better? I am going to talk about Wolverines, believe it or not, but only a little bit. But I'm also going to talk at Tim's coaxing about some things about international multi-center research, which I hope might get us thinking together on how to do that and what pitfalls to be watchful of. Are we picking me up okay with this? All right. By way of disclosures, I have no relevant financial relationships. I have had some international grants that have my name on it for the symposium that Tim mentioned. I want to acknowledge, importantly, some sources of research funding, and also the collaboration of investigators throughout the world that have helped with this research that I'm going to share with you today. I've truly benefited from partnerships around the world. Let me also start with a geographic acknowledgement. We are here right now, of course, and out west are the states that I'm from. I just want to point out that this is where Portland is. This is where Eugene is. So Oregon Health Science University is in Portland. The University of Oregon is not. And I am not from the University of Oregon. In case any of you caught a friendly football game last Saturday with a team that just happens to be #1 in the country, I had nothing to do with that, I assure you. And I'm trying to deflect any animosity one might feel in this audience for those of us who come from the West, and remind you that Michigans have said, I don't often hate, but when I do, I prefer to hate the Ohio State Buckeyes. It just so happens that OHSU looks like the word Ohio in a way, and I have often been accused of being from Ohio. I am not from Ohio. In fact, let's go south a little bit, and I'll tell you where I am from. I grew up in Southern California, very close proximity to the Rose Bowl. And I think you guys know all about the Rose Bowl. This is the Rose Bowl, and my home was just on that hill back there. So in my growing up years, the first time I ever heard about Wolverines was clearly related to the Rose Bowl games. It seemed like every year the Michigan Wolverines were out in our neck of the woods to play whatever foe the Pac-10 could come up with them for that year. And I remember watching many a Michigan game at that bowl game. So I guess that was when I first started thinking about, well, what is a Wolverine? And never really encountered a Wolverine in my life, or not even in books. So in coming to this talk, I decided, well, I probably should know something about Wolverines. And so I started doing a little reading. And I realized that there's 3 types of Wolverines. There's this kind, the mammal of in the northern hemisphere. There's also this kind of Wolverine, and then there's this kind of Wolverine. And I, in the challenge of trying to make statements about what these Wolverines have in common with the systemic right ventricle, I'll disclose right at the outset, nothing. There is nothing. But I'm going to use some things that I've learned about these Wolverines to make a few points about the systemic right ventricle and hopefully keep your interest. So bear with me as I go through this. There are likewise 3 types of transposition of the great arteries that have a systemic right ventricle. The most common is those with what's called D-transposition with an atrial switch, also known as the Mustard or Senning operations, for those of you who aren't acquainted with that. In other words, the right ventricle and the left ventricle are where they ought to be, but there's been this atrial baffle in place to help redirect the blood to correct the problem. There's also something called congenitally corrected transposition, where the blood goes where it needs to go, but the ventricles have swapped positions. Now, the congenitals in the audience, like Tim, etc., will know, well, wait a minute, there's only 2. What are you saying when you say 3? Well, what I mean by 3 is I think there's sort of a separate phenotype of congenitally corrected transposition where they come with a lot more complexity. And so, for example, this patient, the heart looks like the ventricles are in the right place, but it's only because he has dextrocardia, situs inversus, with then levocardia that's bringing the ventricles back to where they are. Anyway, a lot of patients are born with these other conditions like a VSD and pulmonary stenosis. And the 2 are distinct because they're often on different clinical paths. The one in the middle here might be someone who was never diagnosed until they were in their 50s and someone picked up on some little differences and got an echo. The one on the right would be someone who's had multiple surgeries since they were born. Maybe they've already had a pacemaker placed. So they I think, are distinct. Now, back to Wolverines. Lesson number 1 was that Wolverines are quite rare. I did not know that, but thinking that Wolverines would be endemic to your neck of the woods, I learned that they really are not. And that since Wolverine sightings since about the early 1800s have been rare indeed. One was this, which is Bob Brown, coach of the football team in the 20s. He's actually posing with a taxidermied Wolverine there. It looks pretty real. And then there was Benny and Biff Wolverines that were imported from Canada and put in the zoo and brought in when they inaugurated the stadium. Is this known lore here? I don't know, but those were two live Wolverines. And then there was a Wolverine donated by the Chevrolet Corporation in 1930 something. And there was a competition to name this Wolverine. They gave it the name of Intrepidus. And the person who came up with that name got a free Chevrolet out of it. So, and since then, apparently there have not been live sightings of Wolverines in your state until 2004. Correct me if you guys know otherwise. Rarity applies also to the transposition group. There's about 20 per 100,000 people. So if you look at the big house, that might be about 20 arrows pointing into individuals out of a stadium of 100,000. Now, this picture was taken in 1956 before you had that seating capacity, but if you just imagine that would be the case. But not all of these would have been alive to be able to go to the stadium and be an adult. So in actual fact, there probably would have only been about 4 by my estimations. Fast forward to today, a larger stadium, you'd still have maybe that same prevalence, but maybe 1, perhaps 2 would not be alive. Yet a lot of them would have been addressed with an arterial switch procedure, and therefore they wouldn't count as someone with a systemic right ventricle. So you're looking at maybe 9 or 10, somewhere in that ballpark. Now, a tangential story is of this individual who is a survivor. So what we're looking at here is the right ventricle and the left ventricle in their expected anatomic positions, the right atrium and the left atrium similarly. So you have desaturated blood in the right heart as expected. You have oxygenated blood in the left heart as expected. The problem being, though, that that blood goes to the main pulmonary artery instead of the aorta and the systemic circulation. And the deoxygenated blood in turn goes to the aorta. This is a patient who had an atrial septostomy. And in this era, in about 1980 or so, when we were switching from the atrial switch to the arterial switch, the family, I think, were probably told something like, we have this new operation, it's a bit unfounded, it's risky, we'd like to try it. The family sort of felt like that was the only option. They didn't want to do that. They didn't want their child to be a guinea pig. They took the child home, expecting the child to pass away. They should have been offered an atrial switch. Instead, this patient grew up entirely dependent on this atrial septal communication. All of the blood that reaches one capillary bed to another must go across that ASD. Despite it, and in a real testament of biological resilience, this patient went to high school, grew up pretty normally, got married, started a home business, and then ironically passed away of COVID, of all things, just a few years ago at the age of 40. So quite an unusual story. I said something about what every Michigander should know. And I think whether we're talking about the Wolverine itself or a detransposition patient, everyone in your state ought to recognize that these are rare, that they need to be recognized for what they are, and they need special attention. And I guess if you come away with nothing else from today's talk, I hope you'll remember this, that the patient, even in Upper Peninsula, that shows up in an emergency room for an unrelated thing, maybe they need a cholecystectomy, I'm really hoping that the providers up there would pick up the phone and call and get some informed healthcare decision-making to know how to address this patient's needs. Because there are enough nuances to addressing that, even through something like a cholecystectomy, that I think really need to be looked at. So the hope is that all providers, maybe not every Michigander, but every Michigan health provider ought to be wary of who these patients are. Now, back to the Wolverines. There have been gradual changes over time, particularly for this one here. As you know, they live in a habitat that's around the northern hemisphere, usually around the poles. So I don't see, they come down to the Rockies in this map, but they really don't make it to Michigan at all. But be that as it may, their habitat is changing, like a lot of things in our world. This is a reconstructed satellite photo of the Columbia Great Glacier in Prince William Sound of Alaska, and based on data from 2020. If you go back a ways, in 1984, it would have looked like this. Now, there's a metaphorical thing here that helps us understand something about doing congenital heart research. Climatologists are very reliant on old information going back 20, 30 years to get their hands on so they can understand how things have been changing. And that's exactly what we do in our field. To know what happened in 1984 that might be influencing the way things look today is very important. And in the systemic right ventricle, the best data we have on this comes from Scandinavia, where they have excellent birth records and things like this. And one of the largest studies to date was this, of about 500 patients with a systemic right ventricle after an atrial switch procedure. And they show mortality in the survivors over the years. The only risk factor they could identify, though, was having a pacemaker. And I think that just speaks to the fact that they didn't have a whole lot of data to analyze, to know really what were the factors that go into some of the disparities we see in our patients. Note the high infant mortality, too. That's something that's changed over the years. So a follow-up study with 800 patients now found that sudden cardiac death was a little more prevalent in the younger deaths. Heart failure was more related to older deaths. But there was a real lack of clinical variables over time with which they could analyze as risk factors. So still a lot of questions remain. And what we see in clinic is definitely a spectrum of function of the systemic right ventricle. This one on the left has very preserved function, as you can see, hopefully. The one on the right, severely reduced function in the extreme. What you can't appreciate, though, is that this patient on the left is 75 years old and doing strong, mows lawn every week. This patient on the right is 25 years old. So what accounts for this wide disparity in their phenotypes? There's also a spectrum of clinical status. When all of these patients have reduced function, systolic function of their ventricles, and yet the one on the left is completely asymptomatic, works full-time as a mechanic. The one in the middle has had some arrhythmias, is on diuretic, his BMP is sort of climbing, but he's doing okay. The one on the right was transplanted about 6 months later. So the clinical manifestations are also very heterogeneous. And so our questions as providers for these patients is, how can we mitigate the heart failure progress, and when should we offer advanced therapies? When should we pull the trigger on some of the things that might get them out of hot water? I've learned that for Wolverines in the middle, there's strength in numbers. The others are too solitary, but there's a lot of strength in numbers. I look at your big house that I think has held at its peak capacity 115,000 people. That must have been quite electric, and I imagine quite an experience to be in a rambunctious crowd like that. In the systemic RV studies, we have much fewer patients. In our research, we're talking about 5 to 100 patients in a study. And I mean that sincerely. Just last week, someone cited a paper that had 5 patients in it. So we are really at a loss when it comes to statistical power in studying this group of people. And despite that, systemic right ventricle makes up a lot of the clinical care that we give and a lot of the clinical questions that we have. In this study that Tim helped with years ago, about 10 years ago now, Tim, if you can believe that, the systemic RV was 3 of the top 10 research questions in our field. So all this led to a multi-center effort to increase our understanding of heart failure and why that happens in some but not all of these systemic right ventricles. And so with the ARC network of investigators, of which Tim and I have been part, we proposed a retrospective cross-sectional study. Keep in mind, there were a lot of prospective studies that were proposed and considered, but we didn't feel that we had the backing enough, either in money or data, to really pull those off the ground. So here we are at Heart House in 2017, discussing and getting some feedback from people at the NIH, which was helpful. some of that proposal review asked the questions, well, these mustard and sending operations are somewhat historical. They're not being done anymore because you have the arterial switch, which is true. They said, well, why study them at all? This seems like a waste of time. And we had to sort of justify our reasons, which were that we are treating these patients now. These patients are in their 40s, many of them. We're dealing with those complications right now. This is the time to study them. The population isn't disappearing as fast as we think. This provides a unique opportunity to study the pressure-loaded right ventricle as a model. And there are other systemic right ventricle cohorts that we can still appreciate. So we built this study with the following inclusions and exclusions. We were looking at systemic right ventricles in either of those two forms that I discussed earlier, with a biventricular circulation. So not someone with a Fontan or a hypoplastic left heart. They had to have two ventricles. We wanted centers to identify patients from historical records. This was key when you're doing a retrospective study and you want to minimize your survivorship bias. You've got to do more than just look at your last year's clinic list. You have to dig up old records and find who are the patients that were in care that have now been lost for one reason or another. So that was a big emphasis. I'm not sure we can guarantee we pulled that off 100%, but that's what we tried to do. They had to be seen at least twice. This was to weed out maybe the late referrals or the loss to follow-up. Wanted people that were actually in care. And we picked a date for their initial or baseline visit, a time where we could capture their clinical information and use that as a starting point. This was not a random date. And let me just explain why for those of you who might have interest in doing sort of any retrospective research like this. If you look at a timeline, practice patterns have changed over time. For example, we do a lot more BMP or exercise testing or CMR now, whereas 10, 20 years ago, those things didn't even exist. So picking a date back in 1980 or 1990 would give us more clinical follow-up time, but we'd be losing out on a lot of that available data. So this date of 2002 was picked somewhat scientifically. We also did a lot for sample size estimates, and you might say to yourself, well, how do you do that in a retrospective observational study? But keep in mind that what you need to know is what your frequency of an abnormal value is. And let me just take a minute to explain this. So the gray is, we're trying to get power above that shaded area here in this graph. This is a graph of power on the y-axis and the frequency of an abnormal value on the x. So for example, if your metric was something like having a pacemaker and about 50% of your population have a pacemaker, then with say 200, 300 patients, you'll have almost 100% power. But if you're looking at a variable that has much less frequency of an abnormal value, say how often do you have an ejection fraction less than 30%, and maybe only a fraction of your population have that, you start losing power. Anyway, so we by our estimations of availability and so on and so forth, we came up with a number of 700 as our samples target. What we ended up with was 1,700, and I'm kind of proud of that. This was a study that came together well. We had a lot of volunteerism. People were willing to chime in and gave us a lot more flexibility in how we did this. A few things about our population. So of that 1,700, most were of the DTGA variety. The associated lesions were far more common in the CCTGA variety, and that was an expected finding. That's kind of known. There were some interesting distinctions between the two that were also helpful to sort of document. Sinus node dysfunction was much more of a common need for a pacemaker, whereas heart block is more common in CCTGA. Atrial arrhythmias tend to be flutter in the DTGA versus AFib in the CCTGA patients. So our primary endpoints, though, we're looking at death, transplant, or need for mechanical circulatory support. That is the time at which they are no longer dependent on that systemic right ventricle. Markers for when that systemic right ventricle has finally done all it can do. And over about a 9-year period of follow-up, about 9% had that primary outcome versus about 13% of the CCTGA group, which were a little older, by the way. I'll come back to that. So looking at this, we see that most of those endpoints were deaths, and meaning we weren't able to capture them and give them a transplant when they needed. Mechanical circulatory support, quite underutilized perhaps for a group of patients that are expected to be eventually dying of heart failure. So we realized there's a lot of work to be done if we're going to offer these people more advanced therapies. We use the REDCap database, which is ubiquitous. I'm sure people here use that. I think it's an excellent tool. Importantly, for multi-center work, it allows us to limit the visibility of one center's data to that center. So I could not see data from Michigan, or Michigan couldn't see data from Seattle, and so on and so forth. I learned that Wolverines may look different depending on circumstances. This is mostly the Hugh Jackman character. You know, every superhero has sort of its mild-mannered alter ego, according to my sons. And the systemic right ventricle fits that in a way. And so does visiting Portland. So if you thought about coming out to Portland, what comes to mind? Do you think of it as a place where there's nice forest walks or a place of constant rain? Do you think of it as, you know, pleasant cafes and sidewalks, or do you think of it as civil unrest? Maybe all of those could be encountered by a visitor, really dependent on the time at which they visit. And clinical research follows this pattern too. So take, for example, this timeline. And if we had on the y-axis some arbitrary measure of health, which we don't have, but let's just say we had some way to measure someone's vitality, then the course of an individual's life might look something like this, right? Health gradually declines, which means a population of individuals might look something like this, depending on when they were born, when they start that timeline. And that's in essence what our research cohort was. We were taking a sample, a cross-sectional sample, which means you're going to be picking up some at the beginning of that curve and some at the end of that curve. We are arbitrarily calling things before this exposures, and things that happen after this outcomes. But it's artifactual. You can see. It's much like me asking which of these tomatoes is the best tomato. Well, today we might pick the one up on the upper right, but if we came back in 2 weeks, we'd probably pick a very different tomato. So clinical research in a retrospective way has this shortcoming. We designed our study to have a second sample period to maybe help us look for changes and do some further analysis that way and help get around this. The mistake we made, though, was not specifying when that second visit needed to happen. So we had a lot of variation in follow-up time, as it were. There's also evolution of care practices and interventions. For example, BMP use or MRI use, et cetera. All these things have influenced people's practice patterns over time. At bottom line, though, we came up with a population like this. This is the median age for the DTGA group. This is the median age mirror image for the CCTGA group. You see they were a little older, more skewed towards younger ages in both camps. And during their follow-up, they were at these ages. So our follow-up time was, as I said, about 9 years. This odd graph is sort of a look at the whole population in terms of when we started to see them and when we last saw them. The gray dots here are the age at their first visit in a serial fashion, and the blue dots are the age at which we last saw them. And the red dots are the patients that met the primary endpoint. What I see here is a lot of red dots scattered all over, which tells us that these events are kind of happening throughout the course of the person's life. It's not just something that catches up to them when they're 40 or 50. Keep in mind also that this triangle sort of represents, if you imagine how many red dots would be in that triangle, those are our missing patients. Those are our survivorship bias. So just some things to help you think about the nature of doing this kind of research. I also learned that money doesn't necessarily solve problems. It certainly doesn't for academic institutions. I've been very impressed with the campus here as I've been walking around. You guys have a lot of development happening. It's wonderful. I think a lot of studies show that schools are often underrepresented when it comes to funding. And that's been the case, I guess, in Michigan. It certainly is the case in Oregon and many other states that I've lived at. And how about in research? Well, we were, as I said, appreciative of the funding that we had, but from what I saw, it didn't necessarily didn't solve all of our problems. It created some that weren't there before. For example, grants we got about 10 years ago to do the REACH project, if you remember that, Tim. I saw behaviors of people that changed when there was money on the table that hadn't been there before. Certainly, it created a lot of administrative work for me in managing the grant. And for the first year, I probably spent 3/4 of my research time just doing contracts and things like this, and not the science at all. So grants can help, but they can also slow things down. I learned a lot about international data sharing, and I just want to pause and share some of those lessons. Maybe some of you have learned some of these same things. There's been a gradual increase in new regulations and restrictions on international data transfer. This comes from social media, where there've been recognition that Facebook and Apple and Google have been maybe harvesting more information across the world than people want to have happening. And so the scrutiny has spilled over into academic data as well. The COVID and ACHD study that we did, which we were able to do really on the back of the systemic RV study, it really helped get that going. We couldn't obtain dates anymore because that was viewed as a violation of HIPAA, just to have a date of when someone had a COVID test. And even since then, the complexity of contracts and data use agreements has made it very difficult for the Europeans in particular to share their data with us here. So I don't know, maybe some of you are dealing with some of those same challenges. The Wolverine is threatened, I learned. In 2023, the federal government listed it under their watch list of mammals. Certainly, the systemic right ventricles are at risk. They are at risk of heart failure. And a lot of work has been done over the years to try to identify what are the things that are identifying those at the highest risk that it will help us to step in. And our research did that as well. So we were able to generate this multivariate risk score based on our data. And sure enough, systemic RV systolic dysfunction rose to the top as a predictor, as did some of these other things. So we were able to develop this sort of calculator that maybe helps steer clinicians who are trying to make decisions about these folks. Keep in mind that there was, as yet, no large impact from things having to do with lifestyle changes, diabetes or hypertension, etc. I think in the next 20 years, we'll learn a little bit more about how impactful these things are for a 40-year-old. But for right now, they don't seem to be playing into their deterioration. In the congenitally corrected transposition group, we know they're more vulnerable to tricuspid valve regurgitation. This is the systemic AV valve. And those with both moderate to severe TR and moderate RV systolic dysfunction did the worst in terms of their outcomes. So confirming things that we already knew. We looked at events that might help us understand who's doing poorly and when. And a lot of those events we noticed would take a long time to be actionable. For example, having a first episode of atrial flutter or atrial fibrillation. Yes, that was prognostic in our study. And those who had atrial arrhythmias were not going to do as well long term. But if you look at the time it took from when that event took place to when they reached their endpoint, we're talking decades. So it doesn't become something that's really useful in the clinic to help make a decision or two about how to manage the patient. I learned that this Wolverine is somewhat resistant to drugs and toxins, according to Wikipedia and my sons. And it turns out the systemic RV folks might also be a bit resistant to medications. I've been looking at fibrosis and talking about fibrosis for a lot of my career. I think of the myocardial fibrosis as something that's a final common pathway of many defects, that it's associated with arrhythmias, that it correlates with ventricular function, it's non-invasively detectable, it's quantifiable even, and it's theoretically treatable. And so I've said to myself, well, that means that our pharmacotherapies that also target fibrosis really ought to work. Fitting with this pattern are the facts that fibrosis is not only present, but correlates with events. In a study we did years ago, this is a Kaplan-Meier curve from that study, just showing the divergence of the revergence of those curves. This is like the tomato analogy I gave you before. Fibrosis is not a discrete event, of course. It's an ongoing process. So this curve just shows that is the case. CMR findings from our big study also fit the pattern. Ventricular function is there, we know that, for both the right and the left ventricle. Their cath findings fit that. If you look at whether they're dry or wet based on their wedge pressure, whether they're cold and warm based on their cardiac index, our study was able to show with this population recently that if you are warm and dry, your outcomes are better than if you're cold and dry, but more particularly worse if you're wet. And so the elevation of wedge pressure is far more important than a drop in cardiac output, say. So anyway, it's just another feature that fits in with this pattern of heart failure that we all see clinically in general cardiology. When you look at medication use, therefore, it's not surprising to see a lot of common medications, including beta blockers and ACE inhibitors, being used in this population. And yet, if you look at the risk of death from those using it, it's quite high. Now, all of you will say instantly, well, this is a retrospective observational study. Completely true. So the use of these medicines is really a marker of disease progression more than anything. They're being used when the patients aren't doing well, and that explains this mortality. Certainly true. But look at the magnitude of some of these hazard ratios. Keep in mind comparatively that someone on pulmonary vasodilators for PAH with a systemic right ventricle, their hazard ratio is about the same as someone getting spironolactone. This is a quite high number. So if we are ever going to be able to show that these therapies are really beneficial, it's going to take a lot of statistical work to do that. Now, we did a little accounting for confounders, knowing that there's more advanced patients are on these drugs more frequently. But we said, well, which patients are on which therapies? In beta blockers, older patients, patients who are more likely to have had AFib or heart failure or a pacemaker are more likely on a beta blocker. No surprise there. I'm sure you'll all agree. Patients on an ACE or an ARB were older. Otherwise, no other significant differences. We did a propensity matching study. This is what Carla in Boston really spearheaded, trying to match our patients, feeling like we had enough of them with anything, any clinical variable that we thought might influence those decisions about who gets a beta blocker or who gets an ARB. And 17 different ones. You can imagine what they were, right? And we found still no difference. In fact, look at the hazard ratios here for beta blockers. This is still twice the risk if you're on a beta blocker than not. Okay, the p-values here aren't significant. I can't prove to you that these meds are harmful. I don't think that's what this study shows. But the needle is still pointing that way. If we're going to do a prospective study someday powered based on this information, it would take thousands of patients studied for multiple years. And perhaps the only thing we would find that, in fact, they are detrimental. So maybe you could say the ACE inhibitors, okay, the needle is still pointing a little bit towards the favorable end of things, though not significant. So maybe there's a role there. But maybe we need to think differently about our medication use. This morning we asked about GDMT in a systemic right ventricle. And I can tell you based on this, I don't think we know what the GD part of that really means in this population. Here's a digressionary thought. What about myocardial perfusion? Is there a role here? If you think of features of the systemic right ventricle, they have a lot of RV hypertrophy. There's increased mass and wall thickness. There's a single coronary artery delivering blood to this hypertrophied wall. And the coronary sinus drainage is often to the pulmonary venous chamber with the higher pressure in an atrial switch anyway. So all those things that might jeopardize coronary perfusion. Then if you add an agent that's going to lower their arterial blood pressure, perhaps you're jeopardizing that even more. Just a theory. Playing around with some blood pressure, heart rate changes, I was able to show that there's a bigger drop in blood pressure in those who don't meet who met the primary outcome in our study. You can't take this to the bank in any way. There's just too many confounders, but at least to me, it's cause for concern, and maybe we should be more careful about how low the blood pressure gets in these patients. What about sacubitril and valsartan? What about the SGLT2 inhibitors? We've got emerging data now that looks pretty promising. There's an explosion of use of these medicines, of course, across cardiology, and that includes congenital heart disease. But there's only these small emerging studies like this one where you get, a list of patients. That said, we're all sort of watching this research space closely. I tabulated some of these numbers last night of the papers that are coming out on these for the systemic right ventricle specifically, and it does look promising. So maybe we'll have more robust data to support their use in terms of GDMT. So that brings me to the point that Wolverines are not wolves. And likewise, the systemic RV is not the systemic LV. The medicines we use, the therapies we choose for what we think is going to work in an LV might not work in the RV. I'll tell you one more example about that. It has to do with biventricular pacing. So in our study, we were able to come up with 111 patients who had an attempted at CRT. And this isn't so easy anatomically, especially in the detransposition group. You can't access the coronary sinus. Even if you can, you're going to be pacing the same ventricle as your transvenous lead. So usually you have to open the chest and put epicardial leads. But in the retrospective experience that we had, there was a meaningful amount of work done to establish that, but very little in terms of improvement from it. So if you look at the ones who had improvement in their QRS versus not, they tended to be a little younger. But in terms of outcomes, if anything, they had more hospitalizations. In other words, were not different. So I think we need to think about this a little differently. This fits with another study in 80 patients that basically found the same thing. It was not giving us the success and clinical response that we had hoped for, even when you're starting with a wide QRS. So maybe some of the things we do for this patient cohort come too late. Maybe the data are just too incomplete with too few patients and too many confounders. That's certainly, I think, true. But maybe the right ventricle is just different, and we can't make assumptions about what therapies ought to work. Now, I'm going to wrap this up here. We could go on and talk about things like transplant and tricuspid valve surgery or ventricular arrhythmias and so on, which I don't really have time for, but we can discuss if we want. Let me share what I think we've learned about the systemic RV from this effort. That, first of all, it's unique, right? As I just said. That there are important differences between DTGA and CCTGA that have many important distinctions. I haven't really gone into that much. In research, it's so tempting to lump them all together. And I've done that myself. You want the power, the patients are rare, so put them in the same paper. But they're really distinct and need to be considered separately. We've identified and confirmed that major risk factors for clinical deterioration are, not surprising, the systolic function, the QRS duration, which is sort of a marker for RV size, if you will, hospitalization, VT. We can act on these things when they occur. We know that sentinel clinical, it's like a pacemaker and arrhythmia, are slow. They're predictive, but only slowly. We've learned that the wedge pressure is more of a harbinger of outcome than low cardiac output. We've shown that standard heart failure meds or having a cath or having a CRT are really just markers of disease progression. The meds have little or no favorable effect, it seems. And there's the limited experience does not demonstrate benefit for a CRT. So how does this impact my clinical decision-making or yours? To me, how can I protect my patients? Well, I think severe RV dysfunction with symptoms, hospitalization, that's when I start thinking, all right, it's time to start thinking about transplant and how that would work. I avoid beta blockers more than I ever used to. I avoid excessive afterload reduction. I think I'm more free with use of ARNIs and SGLT2 inhibitors. I don't try to do CRT anymore. It's still uncertain when to place a primary ICD. And we try to do tricuspid valve interventions before the systolic dysfunction worsens. It's data I didn't really share with you. But there's also been some lessons for me about multi-center retrospective research. I think volunteerism is high. At least in our community, I found a lot of people willing to contribute, which is great. We work with great people across our field. REDCap is excellent. I think there are limitations of retrospective data, even when you have a lot of it. That goes without saying. You have to actively protect against survivorship bias as best you can. You need to plan your study carefully. You need to consider practice patterns and how they influence things. Some questions are probably better addressed with smaller single-center studies with more sophisticated and standardized tools, say doing a CPEC study where you can control how it's done. And money doesn't solve all problems. I'll leave you with one final thought that in all of my reading about any Wolverine, the word that came up time and time again was ferocious. And I guess to me, ferocious means self-defense, self-preservation. I see it as a bit of resilience too, maybe. And I see that in the systemic RV population. At our meeting this summer, we had a friendly competition to who had the oldest patient of this, that, or the other. And you guys presented like a 63-year-old Fontaine, which is amazing. This is the woman who won it for the CCTGA competition. She was 86 and going strong, doing garden work, etc. I used her photo with her permission, by the way. And a couple weeks ago, she passed away of terminal cancer, not of heart disease. And her husband said, you know, she was in such pain. She was on hospice. We were just waiting for her to go and get relief, but her heart wouldn't give up. And that's what I see over and over again. I'd like to dedicate my remarks today to her. Thank you very much.
Thank you, Craig. That was just a great summary. And I think this data set that you have gathered is going to be really important for us in a lot of different ways. One question for you is that, you know, in the EP literature for mustards, there's a fair amount of data about benefit of beta blockers, meaning patients with ICDs. The one big predictor for avoiding appropriate shocks is being on a beta blocker. So I don't know what your physiologist has come to me and said, you should put all of your mustards on beta blockers. So how do you rectify that? What you're thinking?
Well, we're all going back to one paper that Paul Carrion did, and it's a great paper for what it was, but it's looking at a subset of the population, people that already have an ICD for one reason or another. And it's pretty limited, not many patients. And so I think you add a lot more statistical information there and you don't get the same thing. So we did not find that beta blockers were preventive of shocks. I didn't show you that, but it kind of refutes what he said. Now, I believe in beta blockers. I feel that they have an impact in our patients with arrhythmias. I think I use them all the time. So, but I'm a little more cautious. I'm a little more preventative. I'm a little more willing to try another therapy first than maybe just throwing metoprolol at everybody. So I'm certainly more judicious about just giving someone carvedilol because their ejection fraction is low. But in the arrhythmia space, I think there's still a use. I guess, at least for me, I'm tempered a little bit in that use.
Happy to open up to other questions. I think Edie is going to keep an eye on the chat there for questions from online. So thank you.
Professor.
So first I want to thank Steve and Roz for sponsoring this professorship. It's a wonderful idea, and I look forward to future speakers. I love the notion that you and your colleagues gave a voice to those 1,700 patients. Patients with rare diseases often have no voice, and you've given them a voice. I'm curious, the death endpoint, when you look at those patients, were a lot of them on a transplant list, or have they been lost to follow-up, or what was the story with them?
Great question. We have a paper now coming that explores a little bit more about the transplant experience. They, for the most part, were still in care. They weren't lost to follow-up. A lot of them had antibodies that would maybe make them less of an attractive candidate. Anatomic problems, situs problems that would make them less of an attractive candidate. Especially if you go back a few years, people I think these days are a little bit more inclined to be aggressive on how the anastomoses can go. But that wasn't always the case. So you look back, 10 years, a transplant program and say, no, it's not going to work. So we think there was a lot of that excluded them. Same with MCS. MCS, the outcomes from that are not good. Most of those people never make it to being a transplant candidate, less than half. So transplant is definitely the way to go if you can get them there. And I think we're much more open to that than we were in the past. It's a great question. Because that's going to be our parachute for most of these people, isn't it?
Michigan have a healthy representation of physiologically impaired.
I've heard, yes. They were excluded. We did have a couple that got in there, but since they no longer have a systemic right ventricle, they were not part of our study. Does that make sense? If you do a double switch, is that what you're talking about? Oh, sorry. Oh, right. Yes. Sorry, I thought you meant the double switch situation. Right. Yeah, they were definitely in our cohort. Great question. The answer is they weren't much different in the number of outcomes they were having. They were just younger when they had them. So the same amount of atrial arrhythmias, the same proportion needing a pacemaker, the same amount of tricuspid valve surgery, but they were getting it at age 17 instead of 37. So their curves look like this, but the scattered dots, the events that they have are kind of the same. It's interesting. So, yeah, we talked this morning about the preservation of the subpulmonic left ventricle with some degree of pulmonary stenosis. I think that's very important. But our data set doesn't have anything that can prove the value of that. There's the Europeans that have done a similar study with retrospective data showed that one of the predictors for VT was actually having some pulmonary stenosis. So it was detrimental in that group. I think it's a matter of degrees. I think some pulmonary stenosis is helpful. A lot is not. You start to limit flow. And it sounds like Tim, from what you told me this morning, agrees. Yeah, it's a great question. Yes.
Found some of your comments about coronary supply, because this is going to be very interesting. Has anybody looked at like microvascular coronary flow reserves in the system?
Yes. In fact, that study of 5 patients that I alluded to was one of them. So if you go back several years, you'll find some papers using nuclear perfusion imaging and where this has been looked at, and it is abnormal. They have perfusion abnormalities that you can demonstrate without coronary obstruction. So it is a thing. And along that line, we see a lot of patients in the ER with chest pain. We certainly get that a lot, even with like TETs and other people that have some RV hypertrophy, perhaps. They get chest pain without coronary obstruction. We also looked at that here. A fraction had been evaluated for chest pain in an ER. We also looked at arrhythmias that happen during exercise, because maybe that too is a manifestation of a perfusion abnormality. You get your heart rate up and the supply demand just doesn't work. And it didn't really come out in the experience from our statistics, but it's a real thing, you know, that an atrial arrhythmia could maybe deteriorate into a ventricular arrhythmia. And perhaps that has a lot to do with perfusion. Okay, thank you.